Hello, I'm Dr. Marla Shapiro. I'm a past president of the North American Menopause Society, and today I am thrilled to be talking about menopause care in underserved populations. And let me introduce you to our guest, Dr. Nancy Phillips. She's a board-certified OB-GYN, associate professor and director of the Center of Vulvovaginal Health in the Department of Obstetrics, Gynecology, and Reproductive Science at Rutgers Robert Wood Johnson Medical School in New Brunswick, New Jersey. And her colleague, also from the same location, Dr. Gloria Bachman, well known to all of us, a professor of obstetrics and gynecology and medicine, associate dean for the Women's Health co-directorate at the Women's Health Institute, again at the Rutgers Robert Wood Johnson School in New Brunswick, New Jersey. She's also the medical director of the Proud Gender Center of New Jersey and the New Jersey Commission on Women's Reentry. So welcome to both of you. We're going to talk today about a topic that we also sometimes just don't talk about at all, and that's menopause in an underserved population. So first, identify for me the populations that are most at risk in terms of being underserved.
Well, let me begin by saying that most of the research that is done on the menopause has been done in cisgender, non-Latino white women. So that there are not a lot of data on individuals who we care for every day. And that these are the women who are women of color, the non-Latino white women, even women who have had, very traumatic pasts due to healthcare disparities, that we often think of a specific model of the menopausal woman, and that's not the correct model at all. And therefore, we have to expand it. And as you already mentioned, I see many women now, along with Nancy, as the medical director of the New Jersey Reentry, who caring for reentry women who have been incarcerated. And when you look at the numbers, 81,000 women in the United States are released from a prison every year. And many of these, about 1/4 of them, are menopausal. So they have menopausal issues that are different because it's basically shaded with the trauma that many of these women had. Or you mentioned the Proud Gender Center. Many women are not cisgender, heterosexual, but they're homosexual or they're transgender. So we really have to expand our thinking about who the menopausal woman is, and is she from an underserved population that we have not addressed in the past.
So is it access to care in this underserved population that leads to menopause often not being diagnosed accurately or even being treated?
I think access to care is certainly part of it. I think that we try very hard to reach out to these populations, especially working, through a medical school, through a public facility, to try to reach the population. However, even when they get to our door, sometimes menopause is really not addressed for several reasons. One, from the patient's point of view, they may not bring it up because they either don't want to talk about it, they don't know how to talk about it. From the physician's point of view, often this population has lots of other medical problems, and it gets prioritized by the physician's point or the clinician's point of view.
Right.
And sometimes what's really bothering the woman is her hot flushes, when as a clinician, you might be more concerned about her blood pressure. So there's a lot of reasons why menopause is not addressed.
So let's talk about menopausal symptoms. We often think of this confluence of symptoms. Everybody has the same symptoms, hot flashes, night sweats, and it is what it is. But, in terms of different populations, if we look at Black women, if we look at an Asian population, level of comfort or the presentation of symptoms, how do they vary?
You're absolutely right when you talk about it's not one size fits all presentation, that not everyone presents with hot flushes. Probably one of the most common presentations is weight gain.
Yeah.
So many women, about 5 to 8% increase in baseline weight for most women with menopause. And so they're coming in and they want help, and the hot flushes, they're minimal in comparison to their inability to function very well because they're carrying extra weight or they're not feeling well, they're depressed, and they might not just say, I want hot flush, therapy,
Right.
but rather I have this extra weight that I'm carrying and I don't feel sexually attractive anymore, or, I'm not functioning at the same level because I'm tired, so that it may not be directly related to menopause. So therefore, they may not bring up the topic of
Right.
menopause, but rather other issues that they're having.
It's really important to ask the questions, to take the presenting problem that may be depression and find out, well, why is there depression? In this population, you may assume depression is related to socioeconomic problems or other problems. And certainly it's incredibly important to ask about housing instability, food security, intimate partner violence, but it may not be any of those. And you have to ask the right questions. They may be depressed because they're not sleeping, because they're not being able to sexually function.
You bring up
There's
such an
a reason.
important point. The fact that we often have this bias in terms of
Yes.
when we assess these women as to what it is we think that they want to talk about.
Right.
So universally, barriers to treatments in underserviced populations center around access. Can I see somebody? Can I make an appointment? And then even if I do see an appointment, how do I pay for what it is that they're suggesting? So if these are common barriers, and I assume that they are, what can we do? What can we do to address these barriers and get these women in and get them cared for?
I think getting the women in is a matter of being open to the access, asking the questions when we do have women in. I do believe, when you have the reentry women, they have access to care. It's a matter of what kind of care you're focusing on. It's when they do have the ability to see a healthcare provider, making sure that you're covering all the problems that they may have.
Okay. Gloria?
And as Nancy said, that we see many individuals, it's not necessarily their access, because there is opportunities for insurance for many of them, for the Medicaid, et cetera. But they're actually, they feel there's hurdles to being seen in a clinician's office, that they may not be given respect because of their incarceration history, or because of their domestic violence history, or they may feel that if the partner comes with them because the partner wants to come with them, they may not be able to be straightforward with them, or they may have child care responsibilities or adult care responsibilities. So yes, it is access. That is a major hurdle. But even those that have access often say there are so many hurdles to seeing a clinician, and I just feel uncomfortable sitting in the clinician's office, knowing that people may be looking at me because I'm not the standard menopausal patient. I'm morbidly obese, or I don't speak correct English. I need a translator. Just all of the obstacles that we see in underserved populations.
Another large barrier is cost.
Right.
We have the patient in our office, we recognize the symptoms, we want to treat the symptoms, we want to help them, and the cost of the medications that we prescribe. And I think it's very important for us to work with the patient to get them the proper prescription, or if they cannot afford the prescription, offer other over-the-counter options that may be a little bit less expensive, some non-hormonal therapies that can be generic drugs that can be more affordable for both those with and without insurance. If there is insurance, we can help the patient by finding out exactly which preparation does their insurance cover. We can write appeals. We can there are a lot of pharmaceutical companies, if you directly apply to them, will help you with the cost of medications. So you need an informed office and an informed office staff,
Right,
who is able to help overcome some of those barriers, which is very difficult. We know we're all in healthcare, and we know how difficult navigating insurance is. So for somebody who is underinsured or doesn't speak English or feels uncomfortable with the system, you really need to help them navigate.
So often we bring our own bias as healthcare practitioners to the table in terms of what it is we think these women want to talk about. So from your perspective, serving this population, what is it that a patient wants you to address? How do you open up the door to have a discussion of menopause that's going to be appropriate and allow them to feel the comfort for whatever it is that they want to talk about?
I start with the statement that menopause is a very difficult situation for many women. And then I go through the litany of many of the signs and symptoms that women have, so that if I were the patient, Gloria Bachman, and Underserved, I wouldn't say,
Right.
gee, I'm the only person that has sexual discomfort, or I'm the only person who can't sleep at night, or I'm so depressed, but rather the clinician brings up these topics and has literature in many languages that go through these. So very patient-friendly literature that while the patient's waiting can sit and read and say, oh, so this is common, that many women do gain weight during the menopause. I'm not that unusual. Let me talk to the clinician about this.
Mhm.
So it's basically giving permission and stating all of the issues that women have with menopause and giving patient-friendly information or educational tools in the office, in the waiting area.
What I hear you say is, we often talk about, and when we are at conferences and meetings among professionals, we talk about individualizing therapy. But what I hear you saying is that it's got to start before the individualization of therapy. You've got to individualize the conversation, what you say, how you say it, the time that you take to say it. And I think that that's something that we often don't think about, that individualizing the conversation and not bringing our own potential biases. Oh, I deal with menopausal women. They all want to talk about this, or they all want to talk about that, when in fact, that may not be true at all.
No, it's very true that what I find, especially with the re-entry women, is that many of their issues are trauma-based, that they've had trauma when they were in their community, even before incarceration. Then during the incarceration, it's very traumatic. And when they hear that there are other issues or problems that other women have, then they often feel more comfortable talking about some of the issues that they have that may not be directly related to menopause, but they're not sure if they are or not. So I think having that kind of an opening to tell the patient that you want to hear what they say, regardless of what it is, and that they're not unique, that many women have these issues.
And
I'm going to interrupt you for a second, Nancy, before you go on, because I think the point that you're making here, Gloria, that really needs to be highlighted is that it's not only underserviced, but it's the layer of additional, for example, trauma-informed care plus an underserviced population. That there are many layers to this group that you need to identify and really be aware, which I think perhaps many of us are not necessarily.
And part of what I was going to say before you said that, which
Yeah.
was, part of what we're trying to express, is it's not a one-stop shop.
Right.
And I think you don't always fix or get to the root of the problem or discover what the problem is on the first visit.
Right.
However, what you do is you build a relationship. You make the woman feel that she's in a safe space. You make her aware that if she has had a history of trauma and she's complaining of vaginal symptoms, you may not do a vaginal exam on that
Right.
day if she's not comfortable with it. So there are very many layers to it. And I think women open up as they become more trustful of you, and you are very respectful of them. And I think that really is very important.
And I know that in some offices, it's almost like the prenatal groups that they have where they get women together, that many offices, we do this with reentry, we get women together for circles of care, where we discuss the wellness issues, especially those, of aging and menopause, so that it's just not me, Gloria Bachman, having to think of, gee, what should I say next? Or did I miss anything? But rather, there's Gloria, there's Nancy, there's others who are the circle of care, and we're all discussing the topic. So when I bring up menopause with the women, someone will bring up, my weight, someone will bring up that, I can't sleep at night and, my spouse, my partner is getting so upset, so that everyone brings up something different so that it's not all on you. It's not, it's
Yeah,
not.
but I think it's even more important than in terms of what I'm hearing you say is that often we come in with our agenda. And really, it's time for us to put our agenda aside and let the patient, the woman, the underserviced, whatever it is, have the agenda of what's on their list of things, because their blood pressure and cholesterol may be the last thing that they're thinking
Right.
about, but we're thinking, oh, heart disease, 1 in 5 women, we need to be doing this.
Right.
So I'm hearing you say that the empathy and the ability to let them lead.
And the other thing is we learn from our patients. That's the last thing that I did wanted to say with the circle of care.
I was
You
going to
don't,
say the same
you
thing.
don't
Yeah.
have to have a circle of care. But if the first patient comes in and says A, B, C, and D, and the next patient comes in and only says A, B, and C, then you should be bringing up D, because
Right.
they might have forgotten to talk about D in their, I'm with, the clinician now, and there's some stress.
Which is
Absolutely.
also true in terms of some of the therapies, some of the over-the-counter treatments that we don't know about, some of the other strategies people have, some of the different cultural traditions, some of the ways of talking about things. And you listen to your patient and you learn a lot.
Well, I have to thank you both for joining me today, really to highlight some of these really critical issues in terms of that it may not be a one-time visit, that the patient does have to agenda set, and individualization starts when you open the door and hello, as opposed to when we're writing that prescription.
Absolutely.
Thank you
Yes.
so much both for joining me today.
Thank you.
Thank you.